Hello everyone, this is Dr. Sehar from DENTABEST, your best online mentor for the preparation of INBDE, ADAT and AFK exam. Don't forget to subscribe to my channel on YouTube and visit my website at DENTABEST, where I'm offering several personalized and self-study smart learning programs at a very affordable cost for all my hardworking students. So today I have taken a topic of ortho that says fixed orthodontic appliances. That's a very important topic. So in this video, we are going to discuss different types of brackets, ligatures, wires, development or history of the fixed ortho. Let us go deeper and see what all topics are important here. So let us see the indications of the fixed appliance first. So fixed appliance students, they are used for correction of mild to moderate skeletal discrepancy, intrusion, extrusion of teeth, correction of rotations, overbite reduction by intrusion of incisors for multiple tooth movement required in one arch, or active closure of extraction space or space due to hypodontia. Let us see what are the contraindications of the fixed appliance we have. Fixed appliance are not given the patient who are not motivated. Poor hygiene, of course, we don't want to give the fixed appliance to these patients. Extremely severe malocclusion that is requiring the orthodontic surgery. Let us see what are the advantages and limitations of the fixed appliance we have. Fixed appliance students, they produce variety of tooth movement like bodily movement, rotation, uprighting, torquing, intrusion. Grossly misplaced teeth can also be corrected by using your fixed appliances, and they are efficient in treating lower arch problem when compared to removable appliances. Also, space closure following extractions is mainly done by use of fixed appliances. It can be used for multiple tooth movement. Fixed appliance allow for the control of position of several teeth during the treatment. Also for establishing the normal incisor relationship with both crown and root movement is possible. Now, what are the limitations we have of the fixed appliance? So fixed appliance technique student is complex and requires special training. And definitely chair side time is long here. Maintenance of good oral hygiene is difficult with the fixed appliances, and patient cooperation is required in maintaining the appliance, wearing of elastic, headgears, and the treatment effects are mainly restricted to dentoalveolar structure. Aesthetically, of course, fixed appliances are less pleasing, frequent breakage can always happen, and they are expensive. Now, if you compare between the fixed and removable appliances, so fixed appliances, they have precise three-dimensional tooth movement, while the removable appliance, they have less control over the tooth movement. With the fixed appliance, you can do the bodily tooth movement or translation, while with removable appliance, only tipping movement is possible. Complex malocclusion can be treated with your fixed appliance, simple malocclusion only with removable. High anchorage requirement with fixed, small anchorage with removable. Controlled space closure is possible with fixed. Space closure is difficult. Multiple tooth movement at the same time with the fixed appliance, but the removable only few tooth movements are possible. It can be used in upper or lower arches. Retention in lower arches poor with the removable appliance. Simple to correct rotation, more difficult with the removable appliance. Oral hygiene can be problematic, and removable appliance patient can always remove and clean it. Not dependent on patient compliance because it is fixed, but removable appliance entirely depend on patient to wear or not. Long chair side time with fixed, short chair side time with removable because it just come from the lab, and require extensive training to give a fixed appliance. So fixed appliance are the contemporary fixed appliance are what we have now. They are variations of the edgewise appliance system. And another system of fixed appliance is the Begg's appliance system. Begg's appliance, it contains rectangular slot but does not use the rectangular arch wire. So currently the Begg appliance system has been modified to what is called as tip edge appliance system. If we look at the picture here, fixed appliances, we divide them into edgewise appliance, Begg's appliance, and tip edgewise. And edgewise appliance is further subdivided into the standard edgewise and the contemporary or the straight wire edgewise appliance. First of all, let us talk about the ribbon arch appliance. Ribbon arch appliance, student, it was developed by Edward Angle. It contains vertically positioned rectangular slots in which the arch wire of 10 times 20 inches gold wire was placed into the vertical slot and held with the pin. So this is the diameter of the gold wire. It is 10 millimeter times 20 millimeters. It has poor control of root position and does not generate the torque. Then the Begg's appliance was being developed. It's a modification of ribbon arch appliance in which Raymond Begg modified following things in the appliance. What he did, he replaced the precious metal ribbon arch that was made of gold with actually the stainless steel wire. He retained the original ribbon arch bracket design but turned the upside down. So the bracket is pointing gingivally in this design made by Raymond Begg instead of bracket pointing occlusally. So here the bracket is pointing gingivally. Also, he added auxiliary springs to the appliance for control of root position and cause rotation in the tooth. Advantage of Begg appliance: so the Begg appliance, you can do the tipping movement, bite opening, friction was less, binding was minimized, and the limitation of Begg's appliance is definitely in the finishing because of the complex design and also cumbersome technique. The Begg's technique or modified ribbon arch technique, introduced by Begg in 1950, he introduced the concept of differential force technique, where the bodily movement of anchor molar were pitted against the tipping movement of the anterior teeth. Light forces were used in this technique, and this type of tooth movement achieved in this technique is called as tipping. Stages in the Begg's treatment: there are 3 stages in the Begg's technique or the modified ribbon arch technique. First stage is correction achieved during stage 1. You can correct the overjet, overbite, crowding, correction of spacing, rotation, crossbite correction. In the stage 2, involving the root following treatment objective like maintaining correction that was achieved in stage 1, space closure, molar correction in stage 2, while stage 3 involve movement by auxiliary arch wire, where you can do the root uprighting, root torquing movement. Now the tip edge technique, it was introduced by Peter Castling in 1980s. This is a pre-adjusted type of Begg's appliance. Early stage of treatment resemble the Begg technique only here, and the treatment is finished in the pre-adjusted technique method. So the tip edgewise appliance, it's a hybrid appliance. It's actually a combo of your Beggs and edgewise. So it has a straight wire mechanics of the edgewise and allows tipping of the tooth in the initial stages of treatment with round wires, Begg's technique. In later stages, rectangular wires are used for the tooth positioning. Now let's see the edgewise appliance, what's happening here. The Angle modified the ribbon arch appliance, in which he reoriented the slot from vertical to horizontal and inserted a rectangular wire, right? Instead of having a vertical slot, you were having, see, the horizontal slot here in the edgewise appliance. Inserted a rectangular wire in the horizontal slot that's rotated 90 degrees to the orientation it had with the ribbon arch appliance. This is the edgewise appliance with your horizontal slot. And the dimension in the slot were 22 times 28 mils and wire of 22 into 28 mils, that is millimeters, precious metal was used. Now let us look at contemporary edgewise appliance. So modern edgewise appliance, students, they are of 2 types: standard original edgewise appliance system, and second is straight wire contemporary edgewise in the appliance system. If you look at the standard edgewise appliance system, the rotation of the tooth was controlled by separate ligatures that are tied to the eyelet soldered to the corner of the bands. If you look at the picture here, bracket slot size was 22 times 18 millimeters here, and same bracket on all the teeth. That's why bends were given to compensate for difference in the tooth anatomy. Orthodontic bends that were given in the standard edgewise design, you had the first order bend, second order bend, third order bend. Now the straight wire edgewise appliance are actually the modern edgewise appliance. In these appliance, rotation is not controlled by the separate ligature, but it is having a bracket prescription. It is built in the bracket itself. And the bracket slot is available in these 2 forms. If you look at the picture here, you can see this bracket design, torque in the slot, in this bracket design, torque in the base. So straight wire edgewise appliance has different brackets for different teeth. So this will eliminate the need of wires, need of the bends in the wire, which was given in the standard edgewise. In these appliance, no first order bend is given. Instead, compensation for the contour of labial surface of the teeth is built in the base of bracket itself. In straight arch wire appliance, positioning of the root is accomplished by proper angulation in the bracket slot. Again, the need of second order bends is not there. The bracket slot in the straight wire edgewise appliance are inclined to compensate for proper inclination of the facial surface. So even third order bends is not required here. So this is called as a bracket prescription. Now if you look at the lingual orthodontic appliance, so this technique involves placement of bracket and other attachment on the lingual surface of the teeth. So appliance is not visible, so aesthetic is definitely good with lingual brackets. This technique is called as invisible orthodontics, and it's Craven Cruz that credited with the development of lingual appliance. So you can see the picture, the brackets are present lingually here. So lingual ortho appliance are mainly indicated in case of mild incisor crowding with anterior deep bite, long and uniform lingual tooth surface without any filling, crowns and bridges, having good gingival and perio health is important, compliant patient, skeletal class 1 pattern, or an individual with mesocephalic or mildly brachycephalic skeletal pattern. or patients who are able to adequately open the mouth. You can give the lingual appliance. The lingual orthodontic appliance, you go for indirect bonding, which is mandatory because of irregular lingual tooth morphology. And lingually, it is difficult for you to visualize all the angulations and bracket height. And it is difficult to obtain a direct line of sight for bonding of lingual surfaces. And moisture control is also difficult for lingual brackets. So always you go for indirect bonding. Now look at this. These are called as the self-ligating bracket. So a self-ligating bracket, student, is defined as a bracket which utilizes a permanently installed movable component to entrap the arch wire. So you don't need ligatures here. You have a locking mechanism. So as soon as the wire goes inside the slot, you are going to close the lock. The self-ligating bracket are divided into two types, the passive and the active. So passive bracket, they use a rigid movable component to entrap the arch wire. Hence, tooth control is determined entirely by the fit between the bracket slot and the arch wire. While the active bracket, they use a flexible component to entrap the arch wire. And this flexible component contains the arch wire inside the slot. It will control the movement with the active self-ligating brackets. The self-ligating bracket definitely reduces the friction during the tooth translation. All self-ligating brackets, you have greater patient comfort, shorter treatment time, more precise control of tooth translation, and also reduce risk of percutaneous injury, decrease possibility of laceration. But with self-ligating brackets, sometimes the locking mechanism can just break, and there can also be inability to control the torque.